All right, today we are tackling glaucoma, and I'm going to show you how to lock in what is honestly one of the easiest high-yield wins for your licensing exams. Let's just dive right in.
So here's the big question. How do these exams really test you on this stuff? Because, it's probably not what you think. Most of us prepare by just trying to cram every single fact about glaucoma into our heads. But the exams, they're actually designed to test something totally different.
And that is the secret. It is not about memorization. The people writing these exams are testing your ability to spot classic clinical patterns. Once you learn to see these patterns, the right answers just pop off the page. And that's exactly what we're going to nail down right now.
So here's our game plan. We'll start with the core rules. Then we'll meet the two patients who show up in pretty much every exam question. We're going to pinpoint the one test that matters most, break down the treatment playbook, and then we'll finish by exposing the most common traps. Let's get started.
First up, we are building a framework, a reliable way to ace these questions. The goal here is really simple. I want to give you a mental checklist that just cuts through all the noise so you can tackle any glaucoma problem with total confidence. Let's start with the basics.
Okay, so let's lay down the core rules. Think of these as the absolute non-negotiable foundations for everything else we're going to cover. If you get these right, you are already halfway to the correct answer, every single time.
First, the definition. It has two parts, and you got to have both. One, progressive damage to the optic nerve, and two, a corresponding loss of vision, or visual field loss. It's a two-part problem. For it to be glaucoma on an exam, it has to check both of those boxes.
Now, this right here, this is probably the single biggest trap on the exams. We all connect glaucoma with high eye pressure, right? Intraocular pressure or IOP. But, and this is so important, you can absolutely 100% have glaucoma with a normal IOP. So remember this, high pressure is a huge risk factor, but it is not a requirement for diagnosis.
So, that gives us our exam formula. From now on, when you see a glaucoma question, this is your three-part mental checklist. Number 1, is there optic nerve damage? Number 2, is there visual field loss? And number 3, how does the IOP fit in as a risk factor? You master that little checklist, you're golden.
All right, let's bring this stuff to life. We can pretty much boil down every exam question into one of two classic patient stories. So let's meet the two characters that you're going to see over and over again.
Our first story is the most common type, primary open-angle glaucoma, or POAG. I want you to think of this as the silent thief. Picture an older patient. They're just in for a routine checkup. They feel totally fine, no pain, no red eye. They haven't noticed anything is wrong, but this disease has been quietly stealing their peripheral vision for years.
And story number 2 is the exact opposite. This isn't silent at all. This is a screaming emergency. The patient comes rushing in with sudden, awful pain in one eye. The eye is red, their vision's blurry, they're seeing halos around lights, and here is the absolute biggest giveaway. They feel sick, they have a headache, and they're often nauseous, maybe even vomiting.
Okay, so let's put them side by side. On the left, you've got primary open angle. It's chronic, it's painless, it's gradual. On the right, acute angle closure. It's sudden, it's super painful, and it comes with those huge red flag systemic symptoms. These are the two patterns. That's what you need to look for.
So you've spotted the pattern in the patient's story. Awesome. Now how do you prove it? In this next part, we'll look at the diagnostic toolkit, but we're going to zero in on the one test that definitively tells these two stories apart.
So here's our toolkit. We can measure the pressure with tonometry, we can check the optic nerve for damage, and we can map out vision loss with a visual field test. But the star of the show, the test that tells us why the pressure is what it is called gonioscopy.
So, let's say an exam question forces your hand. It asks for the single most important test to tell the difference between open-angle and closed-angle glaucoma. What's it going to be?
It is gonioscopy, every time. This test is the only way to get a direct look at the eye's drainage system, the angle. Is the drain open, like in our silent thief, or is it physically blocked and slammed shut, like in our painful emergency? This test gives you the definitive answer.
So really let this sink in. If the question is about how to tell these two apart, this is your answer. Gonioscopy. It is the definitive test. This is one of those high-yield facts that just comes up again and again.
Okay, so we've identified the pattern, we've confirmed the diagnosis. The last piece of the puzzle is what do you do about it? So let's open up the treatment playbook and see how the plan is completely different for each of our patients' stories.
For our silent thief, primary open-angle glaucoma, the approach is methodical. It's a ladder. We start with the simplest, least invasive thing, which is usually eye drops. If that's not cutting it, we can step up to laser therapy. And finally, for the most advanced cases, we consider surgery. But for our painful emergency, there is no ladder. There is only one speed, fast. This is an emergency, period. The goal is to hammer that eye pressure down immediately and get the patient to an ophthalmologist like yesterday. Any answer choice that even hints at waiting or just reassuring the patient is dead wrong.
Finally, let's lock all this in by going over the most common exam traps, because on test day, knowing what not to choose is sometimes just as important as knowing the right answer.
Here they are. Trap 1. Do not get fooled by a normal pressure reading. Glaucoma can still be there. Trap 2. Remember the silent thief. Just because a patient has no symptoms doesn't mean the disease isn't getting worse. And Trap 3. The second you see a red, painful eye, plus nausea or vomiting, your brain should be screaming, acute angle closure emergency.
And that really brings us to the key takeaway. I want you to stop thinking about glaucoma as this giant list of facts you have to memorize. Instead, see it as two stories. Two very clear patterns. And if you can do that, you're going to answer these questions with so much more confidence and ease.